just like to say welcome to everybody. It's great to see so many people interested. We're like at 143 people on the Zoom call already. So just to start off, that means it's going to be hard to do any kind of monitoring for questions if you're not using your Zoom hand features in the part to kind of get your thing up the participant list, because even if we get rid of the slides on the we're gonna have a difficult time seeing everybody who's there. So please do use the chat, use your Zoom hand if you've got questions, and also please don't hesitate to jump in. This is we want to give you an update, but we're also hoping to answer your questions and not just be talking at you. That's not the point. So do make use of the chat and the Zoom hands for us to bring you in. And on behalf of INSPIRE, welcome. And Rick, do you have any additional words before we get going?
No, welcome everyone. We're going to give you a 1-hour whirlwind tour of the primary care data reports with some background information and hope to answer your questions along the way. So back to you, Mike.
Great. And so I just want to thank, this is the work of a big group, and so our colleagues who have worked specifically on some of the questions around patient attachment are listed here, but we have many other working groups going along. And so as we kind of come through, if questions come up, just so you know, there's a cross-provincial team with lots of contribution. Any nice maps you see that you like, I do want to highlight Peter Glazier, who's our geographer, who really makes those things available to us. So we're just going to quickly run through. Many people may know us already, but others may not know us as well. So we're going to do a little bit of quick background on our team and the data, summary of the reports, and those of you who were at our earlier webinar when the first round of these reports came in, is just to remind people what's there. So we'll go in a little less detail on that. And then we'll want to spend some time talking about the updates and some of the challenges with some of the updated data in particular. Anything that Rick, and as we go along, I just want you to jump in if I've missed anything before we go to the next slide. Maybe you can talk about this one.
Sure. Yeah. So just to say that the INSPIRE-PHC is a provincially funded research organization that Mike and I co-lead. We've got probably, I don't know, Elliot, 80 investigators across the province. We have very active patient engagement and very active interaction with stakeholders, including policymakers, Ontario Health, Ontario Ministry of Health, many of the OHTs, and I know many of you are from OHTs and have responsibilities. So anyway, just we're really happy to be working with you and with policymakers on advancing data and information and evidence-informed decision-making in primary care, and doing research in primary care to advance methodology and measurement. And meaningful measurement especially. So this is a slide from that's a bit older, from about 20 years ago now, but we are working on updating it, and the numbers are eerily similar in 2022. So we will have an update of this, including some disease-specific measures as well. So within things like hypertension and diabetes, this looks kind of similar. So you can see that, there are a very small number of hospital admissions and procedures and advanced imaging and even emergency department visits in relation to the enormous number of primary care. At the time, and even now, we're able to count mainly family physician or primary care physician visits, but you can see the number each day in Ontario is absolutely massive. And this amounts to, somewhere between 600,000 and 800,000, or even approaching 1 million visits a week. Like, this is just a massive amount of primary care interaction with the general public. So as I say, we are in the process of updating this together with partners like the OMA, and we'll hope to circulate that more widely. But just to highlight the importance of primary care, and I think, as we're all aware, health systems that have strong primary care have better outcome measures, better equity, and greater satisfaction at lower cost. And just highlighting the importance of the primary care sector to Ontario health teams and to functioning of the Ontario health system and other health systems. I think we can move on.
Yeah, we'll go to the next slide.
So back to you, Mike.
And I see a question in the chat about currency of the physician data. We're going to get to that with our updates as to when we go there. So just a quick highlight of what's in the report. Each report has data for the province overall and for each individual OHT. There are a couple of the more recently announced OHTs that we're still kind of working on even their initial data and getting it out, but every OHT has its own report, and we comment on a few things. So one is, how are your patients in your attributed population attached to primary care? We look at the total number, we break it down so you can see how we got there. How many people are registered with a physician in a patient enrollment model? How many can be virtually rostered to a doctor who looks like they have at least some minimum amount of continuity of care? How many have visited a CHC? There was a question about our CHCs accounted for in this, and the answer is yes, we've looked at that. And then how many kids are attached to pediatricians? Because in some areas, primary care pediatrics is important. Other areas, there's fewer. And that leaves us with two types of patients who were not certain about their attachment. Those are who've received no primary care visits, and those who have had a primary care visit from a very low continuity doctor. That's a doctor who sees each of their, sees their patients more than once, less than 10% of the time. So that's like, we're pretty sure those people are not in full scope family medicine, but people who are likely doing only walk-in work. Next slide. And then in addition, we have a more breakdown just on who's in your population. And you get some of this stuff also by your reports that you've received from the ministry or on the dashboard that's being built up by Ontario Health now. But this breaks it down again by those attachments. So you can see, like, of your patients who don't have a family doctor or aren't accessing primary care, all of these characteristics for them. And we look at demographics, patient characteristics like comorbidities, chronic diseases, marginalization, primary care indicators like the types of enrollment models within the PEMS, within the patient enrollment groups, breaking them down into the family health teams, FOs, FIGs, for example. How many primary care visits and the continuity of care for patients, primary care follow-ups, and some important healthcare utilization things like hospitalizations in ED, long-term attachment to home care, et cetera. And then we have some stratified tabs. So we do that for your whole population. And then within the tables, there's a sub-tab for certain priority populations that were common across. Your exact priority populations might not be here, but these are some that were common across multiple Ontario health teams. Patients who had been to the hospital recently, patients who'd recently been in the emergency, patients who have frailty, patients who are getting long-term home care, patients with mental health concerns, and patients who have received palliative care. And just again, there's limitations to this sort of data. It doesn't get to the individual patient level for you being able to do or design interventions for a particular patient or group of patients, because it's not identifiable back to the patients that your groups are caring for. But it does serve to provide an understanding of your attributed population, how they're connected to primary care, and those some of those characteristics to think through the problem areas. And this is our second round, so you might be able to see if there's been any trends or changes for your attached population in the updated information. And the next slide. So potential uses, really trying to understand the scope of an issue for your region. Like if you've got unattached patients and you're trying to do an intervention for patients with COPD, what's that number going to look like for your population? Or if you're trying to understand, because you're doing something in addictions and mental health, how many of those patients don't have access to primary care? It gives you that sort of data, or lets you know where they might be receiving care. So how many of your patients will you reach if you connect with family health teams versus a CHC versus the practitioners who may be in a more private practice family health group sort of a model? and also provides in some baseline data that you can use to set benchmarks for targets as you're undertaking projects. Next slide. And we do work with the other data supports. So we've been working closely with the RISE team and trying to help making sure that they've understood what data is available, how people get access to it, so that they can bring that into their discussions with the teams. And we run some what we call applied health research questions, where certain groups or OHTs have reached out to say, we really need to or want to know more about this. And we have a limited amount of funding that can support some of those targeted requests, but each year that goes around and we look at priority areas to do that. And we meet very regularly with the Ministry, RISE, and HSPN and the OHT folks. So reports. I see there's a bunch of questions in there and people are trying to answer them. So maybe I will, before we get to this, I see Rick has answered there's questions about newborns and kids. So I'll maybe, once we talk about our updated data, we'll talk about that, because there's some very particular issues around the people who are newly getting health cards and getting attached in the data. So where you can access your data is at ontariohealthprofiles.ca. So this is the website. If any of you can do it now on the second part of your screen if you want, or you can do it afterwards. But if you just go to this link for ontariohealthprofiles.ca, it will bring you to where all the data reports are. And there you will find reports on your individual OHT, the Ontario information. You'll find that the last reports were from 2020. The updated ones are bringing us up to, this was the question earlier, end of March of 2022. They are not yet out for all of the OHTs yet, but we are working on getting them up as we speak, and the first ones are up already. So if you go to the next slide, this is what it will look like now. You'll see that the green ones are the ones where we've already managed to review, and I'll spare you the details. It's a lot of looking at the tables for finding small numbers that we are not allowed to report because of privacy legislation. So that's actually the current rate limiting step. We've actually run the data for all of the OHTs and we're doing the privacy review. So in the next little bit, they should come out for all of the OHTs. This is up to 2022. We have added new age categories. So the first INSPIRE reports had all kids in one category. There's been a lot of interest in pediatric care. So we have now introduced basically 5-year age bands through most of the years of childhood, so that people can get a better sense of the kids in their area. The biggest challenge is this question about population attribution. So we'll talk about that a little more, but the attachment of patients, the attribution to your OHT happened a while ago and has not been updated for several years. So when you're looking at the updated reports, it is an update on the people that you already knew about before and does not include any information on people who've arrived to your area, like moved there, newcomers, new immigrants. It also hasn't taken away any people who've left. If they've died or left the province and we can't find them in our data for a while, then they've been removed. But if they just moved to a different OHT, we haven't been able to update that yet. And we will be producing some specific reports for each of you beyond the data that's on this website over the summer. It'll be available a little later. So next slide. Yeah, and so this is the big red, what I was just talking about. It's so if we go if you go to the next slide, just as here's the big issues for this. Numbers for kids under 5 years of age is low because any of the kids who were born after the last attribution was done can't be attributed to any OHT. So anything you see that's specific to your Ontario Health team for young kids is off. And the younger they are, they're just not going to gonna be attached. So we are looking at doing together with Ontario Health, trying to do some things by geography around those age groups, because it really is an important data gap for people who are worried about care for kids right now. The other thing is that your total attributed population numbers will change in this report, and they will all go down, because the only thing we could do was take people out. We have no way of adding new people in. So if you are thinking about the older adult populations and how you might interpret changes in things, probably instead of looking at the actual numbers, you might look about change in percentages over time, just because the raw numbers are going to be off because of that inability to add people in. If you go to the next slide, there are a couple highlights. Even with all that, we know that for all Ontario, we don't have this problem with attribution. The Ontario numbers are good because we don't have that problem of assigning them to individual Ontario health teams. So we have seen a significant bump up in the number of people without a good source of primary care in the last couple of years, and you may be feeling that on the ground in your Ontario health teams. But when you look at your own numbers for unattached patients in your OHT reports, because of those data gaps, the numbers are going to be off. They're only going to be able to comment on if there's been changes in the status of people who were already attributed to your OHT before. So you can look at that. To not everybody moves all the time. There's not always all new newcomers, but it will be likely an undercount. But we also can't tell who's moved off to other OHTs. Rick, I don't know if you want to add more to that. I mean, this is just, I think our biggest concern with the update has been just understanding the issue of the lack of update on the attributed populations.
Yeah, I'll just emphasize that when we're not talking about an Ontario health team, when we're presenting data like you see on the slide here for all of Ontario, this is updated. These are updated data. Admittedly, they're a year old now, but they are at least accurate for March 31st, 2022. At the OHT level, we're applying up-to-date measures to populations that were attributed a few years ago, unfortunately. So Ontario Health is aware, Ontario Ministry of Health is aware. There are efforts to update the attribution model, but anything you get from us or from them for the moment reflects the earlier attribution. And I think it's become a kind of back burner move to the front burner to update the attribution model. So data like this for Ontario and data that you're going to see for kids in a moment is all updated to the date that you see and doesn't suffer from those limitations. But the OHT attribution has not been updated, unfortunately.
Yeah. And I've seen a couple questions. I'll try and answer them. I see questions about if people have lost physicians recently changed practice or left, how that will affect the numbers. And the answer is going to be there's always a bit of a lag. These are up to March 21st of 2022. If the person was considered attached before because they were in a patient enrollment model and they are no longer in a patient enrollment model because that doctor retired and they were unenrolled, then yes, you will see that those patients are no longer attached within your OHT. They may, though, still show as being attached for a little while, because if they had been receiving primary care services to a doctor who is still, around, that we can attach them to at that date, it is a 2-year look back window. So there is a little bit of a lag in the model in showing the changes in who becomes unattached. I'd say, Rick, probably it takes a good couple of years after someone's retired to be certain that their patients are unattached and haven't found a source of care yet. How did we choose the age groups? We chose that, Elliot, maybe, I don't know if we have the age group things up there. We chose the age groups based on some discussions with Ontario Health and what we were asked to, there's always, someone will always want different ages, but we didn't do it by school ages. so I think it goes up to the end of age 4, like under 5, and then in kind of increments from there. Pediatric patients really took a jump up. We're taking a closer look at this because this is a big jump, but virtual rostering plays a more important role in pediatrics than it does in the adult population because of the role of pediatricians. We're trying to sort out how much of this is a real jump and how much might be related to the fact that in a 2-year look back period, particularly for kids that are relatively well and don't require regular visits to the doctor, that there may have been fewer visits and less attachment related to that. So that's sort of a new development. We're really digging into that with Ontario Health and doing some more analysis to try and understand that. All right, next slide, Elliot. We have broken things down by age group. This is the provincial numbers. So again, you can see that really the attachment levels are highest in the youngest age group and the oldest age groups, and there's a spot in the middle, particularly in young adults, where it's a lot lower, which may reflect kind of people's importance that they attach on going to receive care. Next slide. This is the other new thing that we've been working on. And so this is really, I think it helps people to understand in their regions what sort of access people might have to team-based care and which forms of team-based care are available to the patients in their Ontario Health teams. And so this mapping, the size of the circle is the number of patients in your attributed population, and then the slices are colored according to whether people are receiving team-based care. So that's the green. So that would be family health teams and CHCs, whether they are attached to a source of primary care but don't look like they have a team. That's that kind of light sort of tan one, and then the uncertainly attached. So people who look like they don't have any source of care are the kind of dark brown slice. IPCTs included in team-based care. It's a data issue. I think we would include the is this the Jeanette, are you talking about the Indigenous care teams, or are you talking about the there are a few newer models of interprofessional care that may not be included because of not yet a kind of data update from the ministry that lets us do that. AHACs are included in the CHC data, I believe. Rick, I don't know if you know more about the.
Yeah, I'm not sure that AHACs are. It's a really good question, and I think because of data governance issues, I'm not sure that AHACs are. This has been kind of on the table for many years, but I'm not sure it has been worked through.
And I see people are answering other people's questions in the chat for us, which is great. So I'm glad that people are sort of getting that. So yeah, so these are not geographic. We've put the circles where your team's kind of node hospital is, but the if you have unattached patients who somehow are attributed to your team because they've received care through a specialist in your region or through a walk-in doctor in your region or through an emergency department in your region, for example, they were attributed to your OHT originally, and they will still be attributed to your OHT. The other, to answer Rishma's question, the reason we call it uncertainly attached is that it's very difficult to be sure that someone definitely doesn't have a place to go. So particularly those people who've accessed some primary care. So if you, let's say you're a young adult living in part of Toronto, if you need primary care, you go to a walk-in clinic, but you don't have your own doctor. We don't let that person become attached because they don't have like a specific regular place to go, but they may feel like they actually have access to primary care. So we're very careful to use this term uncertainly attached, just to let people know that it's our best assessment of whether they have a regular place to go and receive care. And there are gaps. I saw NPLCs are still a gap because they're also not in our attribution list. There are a few things like that that are still just gaps in the data. And I said, Rick, have I missed any questions that are in there?
There's one that says patients who belong to a family health group, they're definitely part of it. FIGs are a patient enrollment model, and anyone who's rostered to a FIG is considered attached. So anyone in any patient enrollment model is considered attached.
Yes, and maybe also just for the virtual rostering, because I understand from my questions with discussions with some other folks at Ontario Health recently, just to understand the virtual rostering piece. So if you're like me, I'm a family physician in a patient enrollment model, and a certain percentage of my patients will be not rostered for whatever reason. Either they've refused, or they've moved away, and they come in to see me for visits, but they're not rostered anymore because they go to a lot of walk-in clinics somewhere else, whatever. So those patients in this model are still considered attached to me, but only by virtual rostering if they've had visits. So it is important when people are like, why are you including virtual rostering? That virtual rostering is to make sure that we don't leave those patients out, because they do have a source of care. It does create some potential for one of the areas for error. Like if you're a FIG doctor, but you also work in a walk-in clinic, you will be a high continuity doctor because you have your own practice. That walk-in patient will be attached to you. Same if I did any kind of work in that sort of a setting that end up attached to me, because I'm a high continuity doctor who might be working in a different setting. So it's not perfect, but we did do our best to exclude patients who only have seen a low continuity doctor who seems like they only work in a walk-in clinic. Those people are included in our not certain attachment group. Virtual's not oh yeah, okay, the virtual rostering, so this is confusing. It's not about virtual care. It doesn't mean you're attached to a doctor who only sees you by phone or video. And in our updates, we did also update the codes to include the virtual care code. So if you did have virtual care visits, they are included in our attachment model now. The virtual just means you didn't sign our actual rostering piece of paper, and we created your roster based on who saw you. So it's based on who billed the most for your core primary care visits that you had during the last 2-year period.
And I will say the virtual rostering only applies to people who couldn't be formally rostered. Anyone who's in a PEM or who has signed the PEM agreement, that takes precedence. And then the next group is considered if you have the majority of your core primary care visits with, or primary care costs, as it turns out, with a particular primary care physician, and you're not in a CHC and you're not in a PEM, then you get attributed to that physician who provided the most care for you. And if they're a low continuity physician, under 10% continuity, then we consider you uncertainly attached. If they are a higher continuity doctor, we consider you attached. We consider that patient attached.
Yeah, and I'll just verify, Jennifer, what you say is true. So the family health group patients are going to be in that light tan circle on this map. They're attached to a source of primary care, but they don't have access to an interprofessional team. So that's where they would sit.
Yeah, and it's really important to note on this map just how much team-based care varies across different geographies in Ontario, and how much attachment varies across Ontario. Especially team-based care is very dramatically different from region to region and from OHT to OHT.
No, so the pain or addictions clinic, Jeanette has a question about pain or addictions docs. We do, there's only certain codes. So it really depends on the type of codes that are being built. If someone in a pain clinic is building all specialty pain codes, they're not going to get attached that way. They have to be primary care visit codes. Addictions can be more difficult because they often are billing kind of regular core primary care codes. So it's possible that patients could get attached through there in the virtual rostering step. As Rick said, though, it is hierarchical. So like we start with, are you actually signed up with a physician in any of the patient enrollment models, and then we work through the steps from there. Yeah, if you have, there's a comment from Monroe. If you have a region that has a particular thing, like you have a lot of, either you have more NPLCs, or you have a large Indigenous population that is part of an Indigenous interprofessional primary care team, that's a big asterisk on these data, because those are missing things. And so for some individual OHTs, if you understand that about your area, then you're able to kind of take that into account. We've only been able to include the ones that we have a source of data for the patients for. And there's a question about geographic mapping. And the answer to that is we are working on some mapping by geography. OHTs are not geographic, though. So just remember that for your attributed populations, the OHTs are not geographic. But because I think especially with the, we talked a little bit about those attribution model gaps and interesting kids, we've certainly identified that looking at this geographically for unattached patients might make sense from a policy lens. It's not how the first attribution model was built, and possible that might change in the future. But, you know, at the moment, unattached patients are still assigned to wherever they received any sort of care, if they had any sort of touch on the healthcare system, rather than being just purely geographic. So the geographic piece is important.
Someone has asked, I think it was Holly Opera asked about the clinic or practice level. We are working on getting those data, but currently we don't have a source of data that tells us who are the family physicians or clinics in your OHT. And it's a bit complicated because, as you know, some have signed up to be part of your OHT and some haven't. So it's a bit contentious as to who belongs and who doesn't belong. We will hopefully be getting those data from the attribution model, and hopefully the updated attribution model. And at that point, if we get permission, we would certainly want to produce it at a more fine-grained level, both forward sortation area, which of course is geographic, which is not your attributed population, and even LIN subregions, because some people are still using those. But we do not have access, right? We can tell at the practice level about attachment, but we can't tell for your OHT which family physicians are in your OHT. Those data are not yet available outside of the ministry in Ontario Health.
And I see some questions in the chat. I'll comment on the geography. You know, having started my career in Moose Factory, there's very big FSAs in the north. And so, you know, in some rural areas, they're not helpful at all. The data is available. We do have crosswalks to those other geographic units, like the census dissemination areas and census subdivisions. One of the challenges is just the numbers. We are restricted in terms of some of the reporting on how many people in each group. And so it's fine usually at a big whole, like who's not attached for an area. But if you start to get into, you know, how many kids, how many with a certain age group, it can easily drop into the area where we have to suppress data. I think for the geography, I don't know. We haven't clearly determined yet how we will map it. We're talking to Ontario Health and the ministry, and feedback from you all as to what would be helpful, would be useful, like whether we'll use because OHTs don't have geographic boundary maps yet. And they're not supposed to, but it's still probably good for them to think about a responsible area, you know, an area that's closest to them, perhaps. That's how we map it. When you see the map of OHTs on our website that you can pick your OHT off of, it's just based on drive time to the hospital that's the center of your OHT. So the boundaries aren't fixed that you've determined that this is where they are. They're just, this is the closest OHT hospital to a particular location in the province. We may end up using some of the old sub-LIN or sub-type thing boundaries, those we all have for reporting, because we have to find a unit that we can map without the small data issues that's still relevant for you all to look at. I'm looking at the other questions. I'll just try and go through this question from South Lake, Amy at South Lake, and the answer to your question is yes. If it depends, it depends on it's yes, sort of, but or if someone from Newmarket went to Toronto and saw a walk-in clinic doctor, if that walk-in clinic doctor is only a walk-in clinic doctor and they don't do follow-up care, and we can tell they're a walk-in clinic doctor, then they won't be attached to anybody. They would be shown as an unattached patient, but they may have been attributed to your OHT in the past if that was their thing, because they did have a visit with the healthcare system, and that was to the Toronto OHT. So those patients they'll look like unattached in our data, but this is why you have unattached patients that look like they're all over the province that are attributed to your OHT. They've had some healthcare connection to your OHT when the attribution model was first set up. Could be an ED visit, a walk-in visit, whatever. Sub-regions and dissemination. Okay, so I'm seeing some comments on the geography. We'll capture those, and we'll bring those back to our discussions, which is great. And a forward sortation, FSA, sorry, we shouldn't talk in acronyms. A forward sortation area is like the first 3 letters of your postal code. It's one unit that we often use for thinking about geography. And I can tell you they're huge in the rural areas. I lived in Moose Factory, the entire James Bay coast was one that, the first 3 letters were the same for everybody. It didn't matter. You could be, thousands of kilometers apart and have the same forward sortation area in the north. So I completely agree with those comments about rural. All right, so lots of comments about the geography. Any questions besides the chat? Anyone have a question they would like to ask? That's sometimes hard to put your full thoughts in the chat. Elliot, I don't know if we have much. I'm just trying to see if we have that. We've got still a couple more slides, but want to make sure we've had a chance to do that. I don't know that the dissemination area list. Does someone have an answer to that? I'm assuming that was provided by the ministry to the OHTs, because it certainly didn't come in our report. Yes, as a comment, yes, it came in the data packages. Oh yeah, great question from Nicole for new team funding. This is actually absolutely one of the ways you could make use of the data. Like, you will be able to, now there are those, understanding the limitations of who's not in, like NPLCs and that, these data reports will let you see the proportion and the number of patients in your attributed population who do not currently have access to team-based care through a CHC or a family health team. And in addition to that, because of the way the reports are laid out, you'll be able to see, because we have things by model of care, you will be able to have a look a bit about some of the characteristics of those patients, particularly the unattached patients. So this would be certainly useful for doing that in describing where you sit in access to team-based care, both relative to other regions of the province, but also just the actual numbers for your OHT. One more question about the frail. I'm just looking here. I want to make sure I don't miss anything. Frailty stratification. So the frailty, yes, the frailty tab was based on an algorithm that had been developed at ICES for identifying patients with certain characteristics associated with frailty. If people want to know more about the details of it, we've got like a data dictionary thing that we can connect you to, but it's based on again, only what we can get from administrative data, and looks like Rick's answering other questions. So the frailty algorithm was developed out of Ottawa, where they have a group of researchers that's quite interested in this, and we just made use of their definition. Migrant, yeah, there's some people who we won't capture. People without health, I think Rick's answered that one already. People without health cards is definitely a gap. Nicole, you have a question. And well, Andrea's first, actually. I'm thinking Andrea's at the top of my list, and then Nicole.
Hi, good afternoon, everyone. Just wondered, in CHCs where clients are rostered to a nurse practitioner and in nurse practitioner ran clinics, how are these clients that are collected? Are they attached or unattached or in a team base? How is that looked at?
So for the attachment part of the algorithm, if they've been seen at a community health center, so we have a record that they receive services at that community health center, and they're not already attached because they're not enrolled with a doctor in another model, or haven't been seeing a physician for primary care visits in the community, then they will be considered attached by being at the CHC. So it depend on your context. NPs working for a CHC, yes, those patients are included as being attached. Patients at an NPLC that's not a part of a CHC, where we not in the thing, they're not attached. I think I have that right, Rick, right? I mean, there's two separate sort of, it's a stream of, it's the streams of data that come to us to support that.
Yeah, so unfortunately, we don't currently have NPLC data. Jennifer Rayner and others at the Alliance are really working hard on including NPLC data, especially the NPLCs that belong to the Alliance. But it's complex because it comes from the EMRs and the NPLCs have to agree and so on. So that's all in process. So a person who's seen at a CHC and at an NPLC will be attributed to the CHC. And if they're seen in primary, let's say they're a patient at an NPLC, but they make a walk-in visit, they're going to be attributed according to that walk-in visit, because we don't have the NPLC data currently. So they will be misattributed. If they're an NPLC client, they will be misattributed. Same with AHACs, same with people who are not, and quite a few people who don't have a valid OHIP number are also not in the data. So it's a big limitation.
Yeah. Thank you.
I've got Nicole and then Jennifer.
Hi, thanks. A great talk. I'm just wondering, as we're looking at analyzing and using this data for OHT planning and primary care and improving attachment and all that, you know, as a family physician that does not have a data analysis background, how would you like? Are there ways to sort of get you know, more individualized support in looking at this data and understanding it, and sort of, you know, making sense of you know, how we should be, you know, allocating resources or planning initiatives?
Yeah, great question. And so we do have plans over the summer to have some students work with us to try and help produce some kind of more summarized things for some of the OHTs, because we recognize this is a gap for a lot. It's all over the place, right? I mean, it's hard. We also are, if people have outreach, they can get in contact with us. We've done a lot of outreach for people that have questions about their specific data to their OHT. So Elliot's contact and the contact is there in the chat. Do feel free to reach out to us if you've got questions about that. And we're also looking at some kind of patient, you know, more kind of digested ways of looking at things. So in the next couple of slides that we have, I'm going to pass things over to one of our colleagues from our Patient Engagement Center to show an example of how you might do that for a specific OHT, and what that might look like as a more user-friendly sort of report rather than big data table. Jennifer.
Thank you all so much for putting this together. I recognize what a tremendous amount of work it's been to collect this data and analyze it in this way. I had put my question in the chat, but I don't know if it got missed. I was wondering, in terms of evaluation, I'm probably getting ahead of myself, but given how much work it takes to pull this data and these reports together, how will we be able to look at evaluating the outcomes of our OHT and track trends over time? What's your recommendation?
So we only have 2 reports, so 2 points doesn't give us a trend yet. But if these are produced, you know, on an ongoing basis, you for sure you will be able to look already at, were there changes, for example, in attachment to your attributed patients, and you can get quite specific. So let's say you were doing like in our OHT, we're doing a project trying to attach patients who were just in hospital. You know, very specific. It doesn't cover our whole OHT yet. Our best evaluation for QI data on that is going to be data we collect ourselves in the interim, like how many patients did we attach. But if we want to see if we're getting an OHT-wide attributed population impact, we would be able to look at the attachment rate for patients who've recently been in hospital and compare it over time and see how we're going. So it's always a bit in the rearview mirror, because this data is not, you know, like this recent updates to March of 2022. It takes some time to settle, but it could be used for long-term things like that as we get more data points over time.
Yeah, and I think because the attribution model only goes up to 2019, we would not recommend using this new one to look at trends. Hopefully the next one will be updated and the date of the data analysis and the attribution will be the same as it was in 2019. And then so those would be good data points to connect, because if you've had a number of new immigrants or babies born or people moved out, those won't be captured in these data. So the current release actually has a pretty big asterisk and limitation in terms of monitoring trends over time. On the other hand, if you've seen your attached or uncertainly attached population go way up, that's probably true and probably an undercount.
Yeah, and there's a couple of questions about, you know, local data for PDSA, QI things. I think the right source will depend on the nature of what you're doing. Some of these could be addressed through AHRQs if they're population-wide and could be measured with administrative data. Others might be more amenable to working with within your OHT with your partners on things like either data from electronic health records or data from your hospital or other groups that are kind of local. It will just really depend on what you're trying to look at. And John says the next one. Yes, the next one, John, not this one. I think is the correct answer, right, Rick? Don't rely on this one yet for trends. Wait for a further.
Yeah, I would say because of the mismatch between the attribution model and the data analysis, I would not look. You can look at trends, but you have to interpret them with very, very cautiously, because they're rooted in the same population that was attributed to your OHT in 2019. Just to clarify for CHCs, it's only the primary care visits. It's not just doctor's visits. Could be nurse practitioner, could be social work, but it's only the primary care visits. So Jen Rayner has been very involved, the research director for the Alliance, been very involved and very hands-on with the data over many years. And the things like mental health, specialized mental health services, legal clinics, nutrition groups, those are not included. But the visits that are considered primary care in CHCs are included. And so, as many of you know, CHCs don't have formal rostering or enrollment. So we really were only able to say this person had a primary care visit, or at least one at a CHC. And that would be enough to attribute them to that CHC if they weren't otherwise attributed.
Great. Thanks, Rick. I'd like to, Elliot, if you can bring back the slides, because I'm just looking at the time. It's been great to get the questions and have a chance to respond to them. But the next, we want to talk a little bit about, you know, trying to get some more user-friendly, public-facing sort of reports that you can use both within your OHT working groups, people who don't want to look at all the Excel spreadsheets or all of the other sorts of things. And I'm going to pass it over to Maggie McNeil, who's a part of our team from our Patient Engagement Resource Center to talk about some patient and public-friendly data visualization, things that you can do with this data.
Perfect. Yeah, hi, thanks for having me. I'm glad to be here to talk a little bit about this project. I'm a postdoctoral fellow in the School of Nursing, and together with my supervisor, Dr. Rebecca Ganan, who's the director of our PERC group. And so PERC it aims to promote patient-oriented primary healthcare research. And so we were, aware of the role that patients can play and patient expertise can play in conveying this primary care data to the public. And we wanted to contribute like a data-driven but understandable resource in order to have that conversation with the public about attachment to primary care. And we partnered with the Greater Hamilton Health Network. And so we worked with patient partners, both those who were affiliated with PERC and 5 affiliated with the Greater Hamilton Health Network, to create a couple of, public-facing visualizations for primary care data. And so some of what we heard, I just wanted to put it up here in case any of you are thinking about engaging your patient advisors in a similar way. The advisors told us that attachment wasn't an intuitive term for them. And what they felt was really important, you needed to distinguish attachment both from related concepts like quality of care, continuity of care, care experience. And also there's a bunch of other concepts that you need to know in order to have this conversation about attachment to primary care. I would also say both our staff and patient partners at the GIN were really interested in health equity data and wanted to be really upfront, taking our lead as well from Drs. Green and Glazier about what the data can and can't do and who the data do and don't include. Also, the advisors were really clear that we needed to include actions that unattached or uncertainly attached patients can take to try to become attached, and highlight the risks of being unattached and the impact that being unattached can have on your health, without blaming people for being uncertainly attached. And so we also had a chance to speak with some clinicians as well, and they were really excited, as I'm sure lots of you are, about the role that this data can play to guide local decision making. They stressed to us that it was important to focus on all of the uncertainly attached group, not just the subset that receive primary care. They were also excited about how the PCDR can inform policy, and just being aware of how this metric can be a way to have a conversation with the public about attachment, and acknowledging that it might get worse before it gets better. And so we do have the final graphics are being confirmed by our group, but how it shook out was that we had kind of like a primer visual where we talked a lot about what primary care is, who provides it, why it's important. And then we have a second visual that gets into some comparisons across the priority groups as far as the GIN, staff and patient partners. And so I would say it's been a really rewarding process, and I would encourage you all to think about how you could engage your patient partners in these data to help you prioritize certain data points and make this a way for you to have the conversation with the public about attachment locally. And so you have our contact information there, and we hope that the visuals should be confirmed and on our site very soon. And we'd be happy to hear from any of you if you have any questions.
We can put the slides down. We don't have any extras. Yeah, those are great. I mean, the trying to bring the data to a format that's useful for the OHTs, both for your internal work in terms of some summaries and for working with your populations is super important. So thanks, Maggie, for that. It's a great model. If people like the work that they've done, then the question will be about capacity to do them for everybody in the same format. But once you've done the hard work of sorting out what it's supposed to look like, it's always easier to do more for other groups. So thanks a lot for that. Oh, questions about more variables for other reports. So what you can do if you have thoughts about, is there things missing? There's always there's an endless number of things that can be done. It's a matter of priorities and things that are being looked at across multiple OHTs for the reports. And so, and is it available or not somewhere else? So I know that, Ontario Health, again, has been really working hard on the digital dashboards for OHTs that include a lot of acute care reporting and other things like that. So we're really trying to not replicate work that's being done that's around other sectors, but to focus on the primary care aspects of the Ontario Health teams and how patients within the attributed populations are connected to different primary care models and sources of care.
Cécile, please go ahead.
Oui, est-ce que vous comprenez le français? Comprenez-vous le français? Do you
She's asking,
understand French?
she's asking if you understand French.
Je comprends un peu de français.
Oui, alors je vais poser une question en français. Est-ce que vous avez des données à propos des patients qui sont reliés aux soins primaires, des patients francophones?
So Cecile is asking if you have any data related to primary care for French-speaking patients or francophones.
We have not done that as a part of our reports. It's a great question. Rick, I know we went through this at the beginning because we had tried to work with the RISO and some of the other groups around trying to sort that out across the province. And it is partly a data issue, but I think we do have access to some data that could help us through ICS.
Yeah, language and ethno-racial data are actually very challenging at the individual person level because they're not attached to the health card or health card number. They can be inferred through the dissemination area, through the 6-digit postal code mapped to the dissemination area where the person lives, but then you only get a neighborhood, a level measure of whether the neighborhood is largely Francophone or not, or whether the neighborhood is racialized or not. So we really, at this time, we don't have data on individuals who, for example, are French speaking. We don't have that available.
Commentaire. Je crois que ce serait extrêmement important que les données soient entrées sur la carte.
Oui, d'accord.
Les données concernant la langue, c'est absolument essentiel. Aussi pour former, pour que vous connaissiez combien il y a de manques, combien il y a de personnes qui n'ont pas de médecin de famille pour la formation du personnel en santé. Alors, vous ne pouvez pas répondre aux besoins si vous ne connaissez pas les besoins. C'est très important d'intervenir auprès de Santé Ontario, ministère de la Santé, pour que les données de la langue entre dans la carte santé quand on a un service médical. Je ne sais pas si vous avez compris tout ce que j'ai dit.
Oui.
Yes, we agree completely. It would require the Ministry of Health to collect French language when people renew their health cards, and in turn to make those data available at ICS and to researchers. So we don't have those currently, but we agree with the importance of providing language concordant health services for sure.
Oui. Est-ce que vous avez fait des demandes à Santé Ontario et au ministère de la Santé dans ce sens-là?
Yes, they're aware. They're aware of this problem.
Yeah, I will add, Rick and Mike, that we do have some working groups. I know Lise Berry and Simone DeRouge have been doing some work with the Francophone community up in the Ottawa and Gatineau area. And so we can connect with them in terms of how their work's coming along.
If I could just add to that as well. So Cecile, at Ontario Health, this is definitely in our purview, and there are some working groups underway, some core socio-demographic working groups that are looking at collecting this type of information associated with health card numbers.
Est-ce que le gouvernement est réceptif pour faire des pas dans ce sens-là? Ça fait des années qu'on le demande et ce n'est pas fait.
I understood your question. Je ne parle pas bien le français, mais je peux comprendre. I don't know that anyone here can answer that. I'm not sure with the how big of a priority this is within government for timing on doing this. It is something that's certainly been identified. And I don't know what the plans are in terms of timing. For our data sources, we're limited to what we have access to for the reports. I think there might be other ways of getting around it too, like a lot of, if we have better electronic health record data, a lot of providers in their electronic health records do a much better job of recording the language preferences of their patients than the government might do on registration. So I think we may end up needing to address this really important question through looking for different sources of information.
Oui, oui, j'apprécie parce que c'est une nécessité, mais en même temps, si on demande ça aux médecins avec leur surcharge de travail, c'est inouï. C'est beaucoup trop de travail de bureau, puis ils ont des patients à soigner. Alors, si ça entrait automatiquement sur la carte santé, ça éliminerait tout ce travail-là. C'est pas impensable de demander ça aux médecins qui sont déjà surchargés. Je comprends qu'on essaie de trouver des moyens autres, mais le moyen principal n'est pas là.
Yeah, very good points. And we are just looking at our time. We're a few minutes over our time, and I'm seeing people we've drifted off. About half of the people have had to leave to probably go back to clinic or other sorts of work like that. So I'd just like to say thank you so much for everybody for coming out and being engaged and having great questions about getting into the data and how it can be used. So thank you very much, everybody.
Yeah, we really appreciate your engagement, and please feel free to be in touch with us for further issues or questions. And the OHT updated data that are not on the website currently will be shortly, especially except for the very recent OHTs. All the other ones will be within, Elliot, the next couple of weeks or so, I would guess. Okay, terrific. Have a great day, everyone.